we like to be very inclusive in Leeds. Thank you, Mr. Chairman. Good morning, everybody. I don't think I need to give this audience much of a background into colorectal liver metastases. Suffice to say that although we achieve good results from liver resection surgery with almost half of patients living 5 years or more, there's still a significant proportion of patients who present with irresectable disease, and there's a need for novel agents both for the prevention and treatment of colorectal cancer and colorectal liver metastases. And there's a growing body of evidence that omega-3 polyunsaturated fatty acids, or omega-3 fish oils, have an anti-colorectal cancer activity. And we've been particularly interested in one of these, Eicosapentaenoic acid. And when we talk about omega-3 fish oils, we're often comparing and contrasting those with the omega-6 fatty acids, such as arachidonic acid, which forms such a large part of a Western diet. And without rekindling everyone's love of biochemistry, you'll just remember that arachidonic acid is metabolized by the cyclooxygenase enzyme to produce a range of prostaglandins, the most important which here is probably prostaglandin E2. And that's important because cyclooxygenase, we know, is very much upregulated in colorectal cancer, and prostaglandin E2 is one of the key drivers of the carcinogenesis pathway. And one of the ways that eicosapentaenoic acid is thought to work is by displacing arachidonic acid out of the cell membrane so that you get less production of prostaglandin E2 and you offer an alternative substrate for COX metabolism. I said there's a growing body of evidence for an anti-colorectal cancer activity of EPA. This comes from large epidemiological studies, a large number of preclinical studies, but as yet there have been very few human trials, and historically these have been patients with sporadic colonic polyps or healthy volunteers, really just looking at colonic mucosal biomarkers. More recently there was a phase 3 randomized controlled trial in patients with FAP, and 6 months of an oral EPA preparation was associated with a significant reduction in polyp size and number. So, buoyed by those encouraging phase 3 results in patients with FAP, we wanted to know whether EPA had a similar effect in patients who had an established colorectal liver metastasis. So we designed and carried out the EMT trial, which was a phase 2 randomized, double-blind, placebo-controlled trial in patients who are awaiting liver resection for colorectal liver metastasis, using that same preparation of EPA that showed efficacy in the FAP study. And as with any phase 2 study, the safety and tolerability of the preparation was an important outcome, along with biomarkers of the growth and the vascularity of the tumour, and a few mechanistic analyses. And our trial was powered to an endpoint of Chi-67 tumour proliferation index as the primary endpoint. So what did I do? I screened all patients who presented to the hepatobiliary outpatient clinic with liver metastases. Those that were considered operable, I screened and assessed their eligibility for inclusion in the trial. I screened about 200 patients, of which we achieved our target recruitment of 88 patients in 14 months. So I consented and randomized those patients on that first study visit, took a baseline blood and urine sample, and asked patients to fill in a food frequency questionnaire. They then took their study medication that evening, continued it every day until they came in for their operation, when they then stopped their treatment. Prior to their surgery, I took a further blood and urine sample post-treatment, and when the liver was resected, I took samples of the tumour for analysis. Patients then underwent routine post-operative care and were seen back in the outpatient clinic at 6 weeks when I took a final blood and urine sample. In the tumours, I was looking at the fatty acid content of the tumour, the PGE2 content of the tumour, and I did immunohistochemistry looking at proliferation, apoptosis, and vascularity. In the urine, I wanted to look at PGE-M, which is the stable urinary metabolite of PGE2. And in blood, I looked at two things. Platelet aggregation, because there have historically been some concerns that giving large doses of fish oil is associated with a preponderance to bleeding because of a reduction in thromboxane B2 production. So we did formal platelet aggregation studies, and also isolated the patient's peripheral blood mononuclear cells as a surrogate for tumour-associated macrophages, and looked at the NFkB DNA binding. Our patients were well matched at baseline, 45 patients in the placebo group, 43 in the EPA group. I'll just point out that the length of treatment was about a month in both cases. They were very well matched in terms of their demographics, their previous bowel cancer characteristics, and their liver cancer characteristics. And also just point out that there were a proportion of patients who were taking fish oil on enrolment into the trial. They then stopped their supplements when they took ours. EPA was very safe and well tolerated. As we'd expect, there was an increase in upper GI and diarrhea side effects, but only 2 patients needed to be withdrawn because of troublesome diarrhea. No difference in terms of adverse events during the trial, very similar range of resections, and importantly, there was no difference in the red cell transfusion rate, and although I haven't got time to show you, there was no difference between the 2 groups in terms of their platelet aggregation. similar lengths of stay, similar need for HDU stay. Looking at the tumour fatty acid content, if you look at the top left of the graph, as you look at it up here, we saw a 40% increase in the tumoral EPA content in the EPA study group compared to placebo. You'll see some of these patients are highlighted in red. These are the patients that were taking fish oil supplements themselves before they entered the trial. And you'll see that if we excluded those, that trend to increased EPA would become more prominent. We didn't see any increase in tumour arachidonic acid in this study. That fits with what we know from the previous mucosal biomarker studies, that you actually need about 12 weeks of supplementation to see a reduction in arachidonic acid, compared to only 2 to 4 weeks to see an increase in EPA. We didn't see any effect of EPA on tumour proliferation over this 4-week period, and no effect on tumour apoptosis. And I'm sure, as you're all well aware, we don't have any pre-treatment tissue to compare this to, because it's unethical to biopsy liver tumours. That's just not standard practice anymore. However, when we looked at the microvascularity of the tumour, I looked at both the vascular area and the vessel count. When we looked at all patients, comparing the placebo and the EPA groups, there was no significant differences. But if you then exclude those patients in the red that were taking their fish oils or high consumption of oily fish of more than 4 portions per week out of the equation, and the sub-analysis, there's a very strong trend to reducing tumour vascularity in the EPA group. And that fits with some extra in vitro work we did looking at human umbilical vein endothelial cells, and also some of the work coming out of Leicester that is soon to be published, showing reduction in tumour vascularity with EPA. Looking at PGE2, we didn't see any difference in PGE2 intratumorally, but when we looked at PGE-M, post-treatment, there was a significant reduction in urinary PGE-M in the EPA group compared to placebo. And those levels then rose back up to baseline levels 6 weeks off treatment. So there's a reduction in systemic PGE2 production. And a similar trend was seen when we looked at the peripheral blood mononuclear cell NFkB DNA binding activity. On the left are PBMCs that are unstimulated, and on the right, PBMCs that were stimulated with lipopolysaccharide. And the same trends were seen in both, with a reduction in NFkB DNA binding following EPA treatment, then rising back up to baseline levels off treatment, seen in both the stimulated and unstimulated cells, compared to very much flatline levels in the placebo group. So EPA was associated with a reduction in NFkB DNA binding. And as you've already heard, NFkB is very much implicated in transcription of key genes in the carcinogenesis pathway and also in the pro-inflammatory response. So in summary, we were very pleased to show that EPA was safe and well tolerated in this cohort of patients, that EPA incorporated into liver metastasis tissue. We saw a trend that it may reduce tumour vascularity. It reduced systemic PGE2 production and NFkB DNA binding activity. And we would recommend EPA for further phase 3 evaluation, either for the treatment and/or prevention of colorectal liver metastases. Thank you.